Hello everyone, welcome back. My name is Alex Like, and in today's lecture I thought we'd talk about some airway management acronyms. Now, you probably have already realized that there are a ton of acronyms in healthcare. There are a ton of acronyms in all industries really, but healthcare is sort of known for making acronyms for just about every other thing. Now, the reason I think it's important to learn some of these airway acronyms is because when you're managing somebody's airway who is unable to breathe or is not able to maintain an airway on their own, it can be very, very scary. Honestly, that's the best word for it. Be very scary. So the last thing you want to be doing is rushing through this process and forgetting certain things. So that's why these acronyms are very, very helpful. So we're going to talk about a few of them. They're going to cover intubation acronyms, as well as predictors of BVM difficulty, and then a couple of others. So I hope you enjoy. The first acronym we're going to jump into is BONES. Now, BONES is used to predict bag valve mask use difficulty. And there are a couple of different things about patients that may make ventilating them with the BVM more challenging. So BONES is is a very common one. It's the one I was taught, so this is what I'm going to teach you. So B stands for beard, or the presence of any sort of facial hair. This makes it difficult because when you're using a BVM, it can be very challenging to get a good seal, a good mask seal, on a patient who has a ton of facial hair. And even if you do get a good seal, there's always the possibility that air will leak out around the mask where there's facial hair present. So really, your best type of patient to ventilate is one who does not have a goatee or a mustache or any sort of facial hair whatsoever. Now, obviously, please don't take the time to shave them. That's stupid and it's a time waster. But just be aware that if you're not getting a great seal, it's very likely has to do with their facial hair. The second predictor of BVM difficulty here in BONES is obese, and this is for individuals with a BMI greater than 26, which is technically overweight but not obese. These types of patients make it a little bit more difficult because their extra body habitus oftentimes will interfere with the way that you can seal a mask, and sometimes landmarks can become distorted, especially if the patient is severely obese or morbidly obese. So again, obesity is just one of those things that unfortunately is becoming more and more common in America, but it will make BVMing more difficult. The N stands for no teeth, or a patient who is edentulous. Now, you would think that having no teeth would be beneficial. It certainly is during intubation attempts, but when your patient does not have the structure to the face that teeth provide, when you're ventilating them, it's difficult to get a seal. So you really, if your patient has dentures, you want to leave them in. So again, if your patient has well-fitting dentures, please leave them in place. You can remove them prior to intubation, but you do need them in place to form a good seal and to have a little bit of rigidity to the anterior portion of the face. The E stands for elderly, and this has to do with a lot of neck mobility type of issues. It's much more difficult to position them correctly into the mask if they have issues moving the cervical spine or even the upper thoracic spine. And then the last thing here is sleep apnea, or the S, or a history of snoring. And this is simply because these individuals tend to have issues with the flaccidity of their tongue, and oftentimes the tongue will be falling back and will occlude the airway or obstruct the airway, forcing you to reposition it more often than somebody who does not have these similar issues. Now, obviously, if you don't know this information, part of this acronym, or if you don't know any of the information from your patient's family or from history taking, obviously there's nothing you can do except try to get a good seal. So that's BONES, and that's a great one. And BONES is pretty interesting because if there are any two of these criteria present, your BVM ventilation tends to become, it's 2 or more in conjunction is a 75% chance, I think it is off the top of my head, that your patient is going to be difficult to ventilate with the BVM. The next acronym we're going to talk about is the Lemon Law. Now, the Lemon Law is actually useful in predicting the difficulty of orotracheal intubation. So the Lemon Law is made up of a few different things. Look externally, evaluate the 3-3-2 rule, the Malampati classification, obstruction, and neck mobility. So look externally, what this refers to is take a look at your patient's anatomy. You want, ideally, the patient to have a thin, long neck. This makes it very easy to intubate. If your patient has a short, thick, like a football player type of neck, it makes it very challenging to actually intubate this patient. If your patient has like a full set of teeth and they're all protruding in different ways, think like Freddie Mercury from Queen, all the extra teeth, all of this extra dentition is going to make it challenging to actually get in there with your equipment and manipulate the airway and manipulate the mandible in the necessary fashion to intubate the patient successfully. You also want to make sure that, ideally your patient has a full mandible, full jawline. Anyone who has a weak chin or a receding mandible is going to be, by default, pretty challenging. And then you want to look and see if there's any sort of severe facial trauma, which may obscure landmarks and make tubing this individual more difficult. The E stands for evaluating the 3-3-2 rule, which we're going to talk about in the next slide. The M is the Malampati classification. This is a classification of intubation difficulty that anesthesia likes to use. There are 4 classes in it. Your class 1 stuff is absolutely no difficulty in intubation. And then it goes all the way up to class 4, which is your very difficult type of patient to potentially manage an airway using an advanced airway like an ET tube. All this has to do with is just how much of the soft palate, how much of the uvula is visible. So like your class 1 stuff, you can see the soft palate and the uvula and everything is visible in there when they open their mouth. You're all the way up to your class 4 where you can't see anything but tongue. And this could be a transient thing too. Individuals can normally have like a low difficulty or a low Malampati score like a class 1, but today they may be experiencing like angioedema, which would then cause them to swell their tongue, and now all of a sudden they're a class 4. Some individuals though are at baseline high Malampati scores, so just kind of depends. The O stands for obstruction, and this is referring to things like blood in the airway, things like foreign material in the airway, swelling, any sort of abscesses that may be present, and that sort of thing. Again, anything that is in the way, in your path, is going to be challenging. The last thing here in the Lemon Law is neck mobility, and neck mobility is basically the inability to move the neck, and this could be from a cervical spine injury or placement of a C-collar, or even something like an issue with the spine that your patient has at baseline. This would make manipulation of the mandible and movement of the head, although limited when we do this during an intubation attempt, that much more challenging. The 3-3-2 rule. So the 3-3-2 rule is another thing that we should be assessing to gauge the difficulty of orotracheal intubation, and this is performed on the patient just by measuring some things. So the first 3 is the opening of the mouth, and this is from the top of the bottom row of teeth to the bottom of the top row of teeth. This should accommodate 3 finger widths. And you use your patient's fingers to do this, so like that. So if they can do that, they can open their mouth and be able to have 3 of their fingers put in there like that. They can accommodate the equipment that you're going to be using to actually intubate them with. The second 3 is the distance from the mentum, which is the bottom of the chin, to the hyoid bone should be at least 3 finger widths as well. We place that there. And the reason we do this is because if the width here is less than 3 fingers, the angle at which the larynx meets the back of the throat, the pharynx, becomes very acute, and your airway is displaced anteriorly, and it makes it much more challenging to visualize once you get in there. It also makes it a little bit more difficult to displace the tongue if the width is less than that 3 finger distance. The 2 in the 3-3-2 rule refers to the distance from the floor of the mouth to the top of the thyroid cartilage, right there. If the width is less than 2 fingers, again, it makes the angle more acute and more anterior and much more difficult to access, and will usually require like video laryngoscopy in order to actually visualize the airway, because it will hide up there in the neck. So that's the 3-3-2 rule, and you should definitely also consider this as part of your assessment strategy prior to intubation. The final acronym I've included today is SOAP-ME, and SOAP-ME, unlike the other acronyms, does not refer to an assessment. It refers to the process of intubation. So SOAP-ME is suction, oxygen, airways, positioning, medications, and end-tidal CO2. And let's run through it. So the first thing here is suction. Whenever you're planning to intubate somebody or RSI somebody, or you have a crash airway that you're dealing with, you always want to have suction ready and turned on. And this is simply because you can never get to suction when you need it quickly if it's not already set up. When you open that airway, you have no idea what you're going to see in there. You have no idea whether it's, he's got an oropharynx full of blood or vomit. Obviously, all of these things are going to make your view a little bit more difficult. So you want to have suction ready and turned on and ready to go. The next is oxygen, and this refers to oxygenation of the patient prior to the intubation. During, if you need to stop, you've been at an attempt too long, it's okay to stop and pre-oxygenate again. And then following the intubation attempt, always good to have SpO2 on, monitoring oxygen levels as well, but you definitely don't want to forget pre-oxygenation of your patient. So super duper important. Airways refers to backup airways if necessary. It also refers to things like bougie tubes or like advanced airway adjuncts. Have these things ready just in case you run into a more challenging airway than you had anticipated. There's nothing wrong with throwing in a King or an iGel or an LMA in a patient that you've attempted to intubate but have failed. We would much more, we'd be much happier to have you roll into the hospital with a patient who has a King airway after you've attempted to intubate and realized that this was more of a challenge than you had initially thought. So there's nothing wrong with having in a supraglottic or retroglottic airway. And there's nothing wrong with using a bougie tube during an intubation attempt. In fact, a lot of different agencies are mandating the use of bougie tubes during their intubation attempts because it does improve safety. Positioning. Positioning is something that's often overlooked. Intubation is challenging to do under the best circumstances. If your patient is positioned correctly for you, it makes your job a little bit easier. So if you have it available, raise the stretcher up to your level. Some people like to pad underneath the shoulders or the head. Certainly pad if your patient is pediatric and you're intubating, position them correctly. And then make sure you have the airway positioned appropriately when you're actually attempting it. Make sure you're using your tools correctly. Medications. This refers to your induction agents, this refers to your paralytics, and this refers to your post-intubation sedatives or analgesics or anesthetics. So have all your medications ready, including the stuff for post-intubation sedation and anesthesia. Have all that ready to go prior to even attempting. And the last thing in SOAP-ME is end-tidal CO2. End-tidal CO2 is an extremely valuable piece of kit that we carry as EMS providers. So you want to be monitoring your SpO2 levels throughout. You can have an SpO2 on the patient's nose, like a nasal cannula one, prior to intubating, certainly during oxygenating. And then, of course, after you're done, please go ahead and put one of these directly on the ET tube and plug this into your monitor or your life pack. And again, we're shooting for values of 35 to 45 millimeters of mercury on your normal human beings, or at least what you were getting at baseline. So that is SOAP-Me. That is one of the more clever acronyms, and it certainly will give you everything you need and all the things you need to remember during an actual intubation attempt. All right, everyone, I hope you got something out of that presentation. Now, like I'd mentioned before, there are hundreds, if not thousands, of acronyms in medicine. These ones are super useful, so if you forget everything else, please remember some of the airway ones, some of the ventilation ones, some of the RSI ones. And this is because these are scenarios where literally the S word has hit the fan and your patient is in the worst possible way, so you really want to make sure you have all your ducks in a row. Thank you again for watching. Please stay safe out there. Please continue to wash your hands, and I will see you next time. Bye-bye.